All right, Connor, can you hear me? He does? All right. So again, apologize for being late. It was my mistake. I should have reviewed my lecture schedule prior to showing up today. So I'm a big stickler in being on time, being where you're supposed to be. I was actually awake, enjoying a cup of coffee, thinking, got some good time today. I was feeling pretty good. And then I get a call. Not so good. So this is kind of a, I don't know, what do you guys think? That's a little topic, big topic? Big topic. You're not going to learn everything you need to know right now. What you're going to do is try to get an idea of how to think about it. Again, my big thing is not to teach you the step-by-step evaluation of anybody or step-by-step by anything. It's to give you the concepts and the ability and the tools to think and be able to apply in multiple things, because you're going to run into a situation where if every gallbladder was done the same way, we'd have a machine. You go to Walmart, you throw in your quarter, get your gallbladder taken out of Walmart. Everybody's different. Every procedure's different. And it's different every time you do it. Okay. I'm not cool enough to have any kind of money or investments, so I don't have anything to disclose. Let's make it work. All right. All right. So what do we really want to do? We want to prevent the exacerbation of chronic illness that's already present, and we want to avoid unethical behavior. Okay, and the unethical behavior is something that's driven by money. It's driven by over-eagerness of a surgeon, or maybe some ego involved in there too. Step one, I like surgery. It's real easy. Is it a surgical problem? Because if it isn't, I don't care. Step two, do I do that surgery? If you have a fractured femur, don't do that. If you have a femoral artery transection, I do that. Second thing, does my facility support the procedure? If you're going to operate on a newborn baby and to close their defect of their heart, do you do that at this hospital? If you don't, then you're not even, you can stop right there. And then the last one is, does the patient want surgery? Because sometimes they just don't want it. Or they'll just defer to you and go, hey, this is the best thing in the world. An anecdote to that is, when I was a chief resident, our pediatric surgeon decided that he wanted to do a Whipple. Except this lady was like 86. She had end-stage Alzheimer's and could not consent for herself. I told him, I am not being any part of this, because I think it is unethical to operate on somebody who doesn't know for an outcome that's going to be crappy, and she's going to die in 6 months anyway. So this is where you need to make sure the patient understands what you want to do for them and what you can do for them. All right, so this is something pretty cool. You guys have seen this all the time. So I can make any operation and trauma patient. I can make any patient in the world into a critical care patient, and that's how I think about perioperative evaluation. So we go neuro, right? We're going to see something here. It's going to be a note that pops up. Neuro. So what are we worried about in neuro, Dr. Brady?
First, they would themselves.
Right. Right.
Daddy used to strokes.
So there's this huge thing. So you get this one little thing that starts off, and then if you think about all these that come around, that's how you evaluate a patient in the ICU. That's how you should evaluate a patient for perioperative surgery. So the difference is you don't have to do a huge workup. If you're 18, you walk into the clinic and you go, I have pain and a lump right here. You go, well, are you having medical history? No. How much do you run? Well, I was running like 6 miles a day until this happened. You're pretty much covered all those bases up there. And you still have to ask about renal. You still have to ask about heme ID. But if you think about it and you break it down to when I talk to my patient, I do this every time. And then it comes down to this one. Is it the right thing to do? I just did a patient that was diffuse surgery for his perforated appendicitis and his intra-abdominal abscess. So he basically had to go, hey, look, man, you're going to die if we don't do this. Fine. And his response was, thank you for operating on me. I feel so much better now. But the difference is that we had to do a big OX lap and dig everything out than it would have been with just a laparoscope. All right, so that's how I think. Because every patient you meet in the pre-operatively or in the clinic, you're going to have to go over and figure out how you're going to not kill them. All right, so this is what I wrote down. All right, so neuropsych. able to consent, communication, language barriers, culture barriers, right? So if you're coming from Chandler, Arizona, which is a very waspy community of retirees with affluent thing, they're going to ask a whole bunch of questions. There's not going to be much of language barrier, and there's going to be no cultural barrier. Where I practice in El Paso, communication was poor, language barriers existed, cultural barriers also existed. So you needed to be very sensitive to that so that you could communicate what you can't do for your patient. Alzheimer's, age, are they able to consent for themselves? Are they a person who can consent, or is there somebody else that you need to talk to in order to consent them? Why do we want to know about paresthesia as chronic pain paralysis? Because if you wake them up and they have a new paralyzed leg that you didn't bother to figure out prior to going to sleep, that's a problem. Also in here, so if you're doing a thyroid and you don't look at their vocal cords and make sure that there hasn't been a previous paralyzed vocal cord, and they come out and they're hoarse, and you can't prove that that vocal cord was already done beforehand, then it's on you. So all that goes into that neurological workup. And then there's special conditions, right? There's the respiratory failure from myasthenia gravis. There's stuff like HTLV1, which causes tropical spasmodic paralysis. Yeah, that's a real thing. I had to look it up. All right, pulmonary. This is kind of going away, right? People stopped smoking. Darn it. Everybody smoked when I was coming up. Everybody had COPD. Everybody was smoking 2 or 3 packs a day. And now you come here and you're like, you run into it every once in a while. And you're like, this is ridiculous. We used to hear stories from the thoracic surgeons going, when they found a lung cancer, they'd call everybody in because it was so rare. And that was in the 30s and 40s before we started giving cigarettes to servicemen overseas. And then they brought them back and everybody started this massive problem. Cystic fibrosis, bronchiolitis, the history of a lung resection. All this is important so that you know that you prevent respiratory compromise on the other side. And again, the list goes on. This is huge. This is just giving you an idea of how you should think about it, how you should work yourself through it. The majority of them aren't going to have all these problems, but there are a few that will, and you can kill them if you don't do the right things. Mitigating complications again, ABG, spirometry, perfusion studies, etc. All those should mean something to you. If they don't mean something to you now, you need to pull out that chapter of that book and start reading about it. Again, this is a total separate chapter in that book you guys should be reading. Pick one that you like and read it. Cardiovascular. We used to get hung up in this all the time. Everybody used to get a cath or they get a stress test prior to going to surgery. You know, did they have their stents put in? Can you take them off their Plavix? What are they on now? How long ago was the infarct? Do they have current exercise tolerance? What can they do at home? All these things go into that. So the first thing you ask your patients are, if you have stairs, can you walk up your 2 flights of stairs without getting short of breath? Yes, then you're good for surgery. You know, if they can say, well, I get out and I do lawn work. What does that mean? Well, I'm pushing a lawnmower for a half acre. You're okay. We can take you to the operating room. We don't need to do any more workup. What we found in the early 2000s is that we were spending a lot of money on cardiac evaluation and achieving no benefit to the patient except delayed surgery. And then they would get pushed back and then they die from some other disease. So it's a big thing. Just ask them, what can you do? Tell them to be honest. If they weigh 4 bills, they're telling you they're running marathons, probably not being truthful. Just say it. Renal, preoperative labs. Medications are cleared by 1 of 2 ways, well actually 3 ways, but the 2 big ones that we concern ourselves with is liver and renal. So renal is a big thing because we want to know how they're going to process the chemicals we're going to give them to put them to sleep, to wake them up, to take care of them as far as infection goes. You want to know what their stage of the renal failure is because again, if you document it coming in, then you prevent yourself from being held accountable for the renal failure that was present on admission. When's the most recent dialysis? Do you need to land this patient in between I just got dialyzed yesterday and I'm going to do surgery today and then they're going to go back to dialysis tomorrow? Those are the things you have to think about. Complications. Diabetes. It's like the devil of all of medicine now. Prolonged hypertension, cardiovascular disease. All those things you have to ask that patient, which is good because you got a patient. They'll talk to you. They may not be able to tell you what you want to hear in doctor terms, but they'll be able to tell you that their sugars are too high and they get headaches and they give them this pill and it makes them pee. whatever. Also the timing of antibiotics, drug clearance, etc. All right, gastrointestinal. All right, nutrition. Just because you're 4 pills does not mean you're adequately nutritionized. All right, so somebody who is obese can be malnutrition. Cachectic, we see these patients more than not. The bowel obstruction or nursing home patient that just hasn't been eating from their end-stage Alzheimer's that they tell us, hey, we need to emergently operate on their bowel obstruction. And you go, okay. Damn it. Go back. See. And then also think in advance. Think about your nutrition prior to where you're going to do. If you're going to leave somebody in discontinuity for a bit, or they can't have a straight way to eat by their mouth, you need to think about how you're going to adequately nutritionize them while you're waiting for that period to happen. Here, I'll give you one of my F-ups that I just did lately. So we had a guy who got kicked by a horse. He had to do a denum, blew out 7 centimeters in his C-loop. We closed that primarily. I did a gastro J and I did a pyloric exclusion. You know what I didn't do? I didn't put a feeding tube in because I said, it's a gastro J. I did it personally. It's big. It'll be fine. Well, he hasn't opened up yet. And now he's like a week and a half out. And what I should have done is put a gastro J in at the same time I had him open. Because I thought I was preparing for the nutrition thing, but what I ended up doing is not preparing for the nutrition thing. So it still happened. Dietary consults. If they think they're undernutritioned or there's something going on, send them to dietary. Get them fixed before you have to take them to the OR. If you don't have that option, then you just bite the bullet and you go do what you can. You can try to maximize their nutrition. Again, ask your patient what's going on, how they've been eating. Are they losing weight? Are they gaining weight? Endocrine. The dreaded pheochromocytoma. How many have you seen a pheochromocytoma or operated on one? Yeah, usually you see 1 or 2 a whole career. So if you've seen it, you've probably seen it. So this is bad. I'm not going to go into the pathophysiology. That's a whole other lecture that goes with that. But that is a dreaded piece of equipment right there. And if you get into that without knowing that it was there, yeah, you pretty much should have just shot the patient in the face and walked off, because they will not do well. Diabetes is huge. Control the diabetes. This hospital irritates me to no end that I walk in, I see my patient who's on the floor, who's been there for 2 weeks, whose blood sugar is 280. Can we not do a better job? We can, all right? Because that elevation and that hyperglycemia hurts every organ in their entire body, including their eyeballs. Hypothyroid, parathyroid, that gets to when you're in the ICU and when they're not doing the things that they're supposed to be doing and you're trying to figure all that out. Say infectious disease. Do you have an infection walking in? Do you have a reason for them to be immunosuppressed? HIV has a whole different thing when they consult you for abdominal pain on it. So those immunosuppression, infectious disease things mean something. Bleeding disorder, genetic and acquired. So that could be somebody who's a trauma patient who's now hypercoagulable, or it could be somebody with Christmas's disease. You know what that is? You need to go read that chapter too. All right, because I've operated on one of those patients. Didn't know about it first off. When they had plate-sized hematomas post-op after we took out her appendix, we went, hey, that's a problem. History of bone marrow-based disorder, cancer, sickle cell trait, sickle cell, and previous transfusions. Menorrhage is also an issue as well, so just make sure you understand what's going on so that when you pull their preoperative labs, you understand where they're at and what you can do to maximize them. Ethical issues. All right, take a little bit of time with this one. So everybody's sitting here going, oh, I have no ethical issues. I will do only what I'm supposed to do when I'm supposed to do it. So help me, whatever you pray to. So the first thing you want to do is informed consent, right? You want to be honest with the patient, and you can consent a patient to do anything you want. It's kind of like being one of those illusionary people that work, magic and so forth. It's how you sell that to the patient, and if you're a good salesman, you can sell anything to them. The question is it the right thing to sell, and should you be selling it? The gentleman that we just did who didn't want his perforated appendicitis taken out, I just basically told him, you're going to die. And he goes, oh, like you heard this before, I'm sure, but now you're really going to die because you're getting worse. And so all of a sudden, he switched his mind and said, okay, let's go ahead and get the surgery done. Well, what was the difference between the way I approached the guy and the guy before? I don't know, maybe 2 days of pain, 3 days of pain, got him to the point where I could break him, or not. The other thing is, we always get all spun up about informed consent. The Brits, having worked with him extensively, want you to consent a patient before trauma. And even if you don't consent the actual patient, you have to write out a consent form because they're big that way. And I looked at him and I go, this guy's got a leg blown off. Do you think he can consent? Do you think he can say, yes, please do whatever procedures I need to fix my leg or not fix it? And you look at him and you're like, you've got him in so much pain. Like they're going to say anything. How many people have done an appendectomy that said, you can do whatever you want, just make this stop? So for me, I'm still kind of hung up on that. It's like, is that ethical to say, hey, I need to operate on you? Well, okay, I'm going to tell you I'm going to operate on you. You're going to say yes because you don't really care as long as it stops. What's that? All right. So the physiological status of the patient. So my mentor was Dr. Hetz, Colonel in 1H, green in color. The Afghanistan books and all that, he was a big, probably one of the gods of general surgery in the Army. Said, if the plane's going towards the ground and the pilot looks over his shoulder and said, hey, can anybody else fly this thing? He goes, maybe you should see what's going to happen the next 10 minutes before you jump up in that seat. Which means if somebody calls you on a patient who's doing the circle to the ground, they don't all have to die with a scar on their belly. Everybody thinks they do because you're magic. And you should take great pride in the fact that you're magic and that you make everything better. You know who they don't call in an emergency? Medicine doctor. Doesn't happen. They don't go, quick, get me the family practitioner in here right now. They go, get me a surgeon. And you're like, what am I doing? I don't know. It's like, because you make decisions. So know what the physiological status of the patient is, because if you get them in a position where they can't consent. I told this guy, the guy who was just the other day, I said, that's okay, you don't have to consent today. You're going to pass out because you're going to get septic. Then I'm going to talk to your wife, she's going to consent you, and I'll be able to do the surgery anyway. Or you can make that decision for yourself. So there's ways to get around it. Now, so if they're dying, what? What, you don't think so? Come on, doctor. Come on, this is a two-way conversation. Go ahead. What, go.
Especially, sometimes I get patients that are like, oh, okay, yeah, that sounds good. And I know, I can look at them. You have no idea what I just said. And I did that the most layman's term that I have.
Yeah.
And they have no idea what I'm telling them.
The guy whose son brought in part of his tibia after he blew it off with a mortar in a plastic bag to show everybody. Yeah, you're dealing with that. Sometimes you just got to go, I know we're not supposed to be paternal, but you just pat him on the shoulder and do the right thing. And if you don't feel like doing the right, feel if it is, just ask somebody and say, hey, am I doing the right thing? Because it's not, I ask Dr. Sammer all the time, it's like, what are we doing? Am I doing the right thing? Should I think of something else? What should I do? Because he's got X number of years experience, I got X number of years experience, we add those together, and then we have Griffin level experience, right?
I think a very important point Rachel raised, that's why it's alert oriented, not times 3 but times 4. Time, place, person and situation. So if you can make them repeat what you said in terms of understanding. You have to quiz it, called a mini mental bedside. That's how it helps to know what's going on.
Yeah, but if they don't, sometimes you go to their next of kin and they're driving a gear and they're just
And that's when you go, yeah, my sister's pretty retarded too. And I would do the right thing for her. And I don't mean that in a mean way. I mean, she just has problems. Oh, no, she's mine.
Yeah.
No, I said mine is she's the one that said that she didn't like Idiocracy because it wasn't funny. And I told her it's because it's about you. So.
But that's a cultural thing, like settling in, when people say interesting, I used to think is always good. But other way of interesting. The
Interesting.
tone, decibel also matters, you know. Anyway, that's
All
a
right.
different conversation.
All right, so that was pretty much the whole thing. This is, again, if you want me to take the book out and go page by page with you, which is not my job, which is your job. I don't care what book you pick up, what reference you use. If you don't read this year, you're going to be in bad shape. Treat the patient, not the problem. Patient first always, problem comes second. We tend to focus on what's bleeding, what's dying, what's going on, but you got to talk to the patient, make sure they're okay. Don't be a technician. Somebody tells you to put in a J tube or a G tube, you go, why? And what's going on with the patient? What's happening? You're not a technician, you're a surgeon. When they consult you, they didn't consult you for a G tube. They consulted you for a surgical evaluation for possible feeding tube placement. Your job is to evaluate the patient, determine if they're able to have a G tube placed safely, and what source of where it should be placed. That's your job. It's not, we're going to put a G tube in somebody. Do the right procedure for the right patient. If you're 89 years old, you got Alzheimer's, and you have a head of pancreas mass, you probably don't need surgery. Just saying. There's people that'll do it. And you know what? According to the book, they're right. But there's a little guy on my shoulder that says, probably shouldn't do that. Hey, look. No matter what you do, patients are still going to have complications. And everybody's going to come back to you and throw rocks at you when you get there. It's like, why didn't you get that cardiac evaluation? Well, he said he walked 3 stairs, 3 flights of stairs. He was lying. He had a pack of Camels in his front pocket. What were you thinking? So, but just, you can only do what you can and make sure you do everything you can to prevent perioperative complications. Go with that. All right, so I got 5 minutes. So it wasn't going to take the whole time anyway. So the whole thing, welcome to general surgery, those that haven't been here before. If you look at a certificate from surgery, from the American Board, we're not board certified in general surgery, we're board certified in surgery. So you recognize that every other specialty has to have a second name with theirs. So I'm an orthopedic surgeon. I'm an ENT surgeon. I am a OBGYN surgeon. You're the only certificate that's made that you are a surgeon, that's your name. When somebody calls you a general surgeon, just go, no, I'm a surgeon. Everybody else needs to differentiate them because it's still board certified in surgery. The other thing is it's a hard job. You wanted an easy job, you should go pick something else. You want to finish it up in 3 years and work 8 hours a day, go be a family practitioner. You want to do great things and be the person somebody calls when bad crap's going on, this is the place to be. You're going to come out with great training out of this program as far as open surgery, big cases. And as much as you guys think that you don't do good trauma here, the rest of the country would beg to be in this facility, as much penetrating trauma as you get. And if everybody who thinks they want to do minimally invasive surgery and robotics, the program I came out of, everybody comes out robot cert. Everybody, we had 3 MIS surgeons. Nobody knew how to operate open. So there's bad sides and good sides to everything. So again, thank you guys for taking up the torch and moving forward. It's going to be a suck part of your life. Believe me, if you don't think about quitting at least 3 or 4 times, like when I left my second year after I came in, I was the surgeon of the day. So you covered everything, surgeon of the day. I presented a case. I was already off. I was on to my research year, which is my 3rd year. And I got yelled at for 30 minutes straight by our surgical oncologist, who happens to be a year ahead of Chu when they went through Roswell Park together. And he just yelled at me, and I just sat there and I went, I'm going to go to urology. There's no reason for this. And it was on a patient. It wasn't even my fault or whatever, but I got just chewed. And I'm like, this is my last day. This is what I walked out of the hospital and went, doc. It took me 6 months to say, okay, I'll come back and do it again. But just recognize everybody's had those thoughts, and everybody's had those tribulations. But if you just got to stick with it and read. I can't push the knowledge into your head. You have to read. The other thing you have to recognize is that this is a big mountain. You can get up it fast, you can get up it slow. You're still going to have to get up to the mountain. Everybody wants to be up there. It's really cool to get up there, but there's no helicopter to get you there. And that mountain is built on your knowledge base, your experience, and your time in the seat. how much time in the seat that you have. And when you're ready to get up there, you'll be getting up there. But until that time comes, take the time to learn and learn from everybody. Like I said, that my favorite thing is learning from your own mistakes, but something even better is learning from always mistakes, because then it doesn't affect you, but just learn.